So we're going to introduce complications of pregnancy. What we're going to do is talk about hemorrhagic conditions of early pregnancy and set the stage for the conditions of late pregnancy that cause bleeding. So we're going to start with the hemorrhagic conditions, bleeding conditions that occur in early pregnancy. So largely what that is, guys, is a spontaneous abortion. We label that as an SAB. It's defined as a miscarriage that happens sooner than 20 weeks. And this is where it comes into play about what the products of conception are considered. They are considered, it's considered a burial if it's over 20 weeks and not if it's under 20 weeks. Most often this occurs, guys, early on, so less than 12 weeks, and it's usually due to a chromosome abnormality. This is where nature sort of takes over, and if there's abnormal chromosomes, most of the time the pregnancy will spontaneously abort itself. So chromosome abnormalities account for about 50 to 60% of these miscarriages that occur before 12 weeks. So there's different categorizations of miscarriages. So a woman could come in, any woman who comes in, I should say, that has vaginal bleeding, we label her a threatened AB. So she is considered threatened because she's bleeding, and so why is that bleeding occurring? It may be a miscarriage. She may go on with a threatened to have a complete successful pregnancy, or she may go on to have a complete miscarriage or abortion. So we're going to, anyone who presents with vaginal bleeding, it's considered a threatened abortion. All right, inevitable means that her membranes or cervix are already, her membranes have ruptured, her cervix is dilated. It's inevitable that this will be a miscarriage. Incomplete means the fetus has passed, but the placenta is still there. This woman may pass the placenta on her own, or she may need to have a D&C, which we'll talk about, which is removing the contents under surgery. Okay, a complete miscarriage is when everything has passed. So placenta is out. The woman is considered to have had a complete miscarriage. Placenta and fetus have both been delivered. Usually at that point, we don't need to intervene with surgery because it was a complete. A missed AB means that the baby has died. There's no fetal heart rate, but everything, the products of conception, are still in the uterus. Nothing has passed. So she sometimes needs to be given medication to induce that process, or we can do watchful waiting on those women, and usually they will spontaneously start to bleed and pass what's in there. Again, all of these guys are happening before 20 weeks of pregnancy. Okay, and we consider somebody to have recurrent miscarriages if she's had 3 or more. One of the major causes of a recurrent miscarriage is a bleeding disorder, so a clotting disorder in mom. This is usually MTHFR or factor V Leiden. These women have a propensity to throw a clot for themselves, and then when they're pregnant, they send a clot through the umbilical cord and it clots off the pregnancy. These women, usually if they've had 3 miscarriages or more, will get a workup for clotting disorders and will be started on a blood thinner, which amazingly will keep them pregnant. That blood thinner that we use is called Lovenox. Lovenox works wonders, but typically insurance won't pay for that workup until somebody's had 3 or more miscarriages. Okay, so the first sign that somebody's having a threatened miscarriage or threatened abortion, TAB, right, is that she has vaginal bleeding, which we defined on the last slide. Vaginal bleeding. So therefore, anyone, right, with vaginal bleeding is considered to have a TAB, a threatened abortion, and any woman who's having vaginal bleeding should contact the provider ASAP to be worked up. What does the workup involve? Usually an ultrasound, transvaginal if she's early on in the pregnancy, and doing a serum HCG level to check what her pregnancy hormones are. Now, if we just do one, we get a number, right? But if we then do a subsequent one 12, 24 hours later, if it's not increasing, if it's decreasing, then we know the pregnancy isn't developing normally because it needs to double for a normal pregnancy. And if it's not doing that and decreasing, we know something's abnormal. And then if it is diagnosed to be one of the categories we talked about for spontaneous abortion, she may have a D&C. A D&E usually happens if she's further along. That's you dilate and evacuate as opposed to going in with an instrument and just scraping out the contents, which is a D&C. Other women will do watchful waiting. They'll say, I just want to start bleeding on my own. I want to wait for this to happen. And then we follow up with them once a week. And we usually give them 2 weeks to start the process on their own. If they don't bleed and pass everything within 2 weeks, then we do recommend a D&C at that point. Okay, so this spontaneous abortion is very different than a termination of pregnancy. The termination of pregnancy, or TOP, is an elective procedure. All you need to know about this, right, is that it can be done medically up until 9 weeks gestation, so 9 weeks from the LMP, and women are given oral medication, and this will 95% of the time induce an abortion. If it doesn't and they've taken the medications, these patients need to agree to then go on to a surgical abortion because these two medications are not safe for a developing fetus. So once a woman goes down the path of doing a medical abortion, if it's unsuccessful, which it can be 5% of the time, she needs to then have a surgical abortion. So surgical is usually an aspiration or a dilation and evacuation. They're done in outpatient centers. Some are private, some are through Planned Parenthood. Patients can choose where they go for them. Most private practices will refer out for these. They don't necessarily do them themselves. In New York, it is legal to have a surgical abortion up to 24 weeks gestation, which can get a little dicey when we think about it because 24 weeks on the other end is the point of viability. Connecticut is not that far. New York is the only state that goes up to 24 weeks. There is a low complication rate that from a termination. It's a less than 1%. So an interesting fact, it is safer to have a termination of pregnancy than to carry a pregnancy to term. I know that sounds really strange. However, we are at risk for clotting. We are at risk for other complications when we carry our pregnancy to full term that don't occur during a termination. So I will say that for a woman that has severe medical issues, cardiac disease, things where it wouldn't be safe for her to be pregnant, it is safer for her to terminate early on in her pregnancy. Okay, so the other hemorrhagic conditions of early pregnancy that I want to decipher for you that are different from what we've just talked about are an ectopic pregnancy and a molar pregnancy. So we'll start with ectopic, which I know you guys know. It's a pregnancy that occurs outside of the uterus. 98% of the time it'll be in the fallopian tube, and I want you to think about who's at risk for this. So you could think of somebody who's had pelvic inflammatory disease, which is caused by an STD, and that causes scarring in her tubes. And so the once that embryo, right, cannot move through her fallopian tube because of the scarring, so it's more likely to get stuck to that fertilized egg, right? It can't move further because of that scarring. Somebody who's had an ectopic in the past is at risk. If this isn't diagnosed properly and it ruptures because the tube is small, and as this embryo starts to grow in the tube, it will rupture. That can lead to maternal death, or it could lead to her losing her fallopian tube because once it ruptures, it's really hard to save that tube. The signs of an ectopic pregnancy are clearly she's missed her period, she's had a positive pregnancy test by urine or even by blood, but this woman comes in and she has severe unilateral pain. So clearly either on her right or her left, she's experiencing a good amount of pain given the ectopic. So what do we do for these women? We check their HCG levels and we do an ultrasound. We wouldn't see a pregnancy in the uterus, we would see it in the tubes. And these women typically present with bleeding. This is showing you again all the different positions where an ectopic can be. It can happen in the cervix, it can happen all over, but again, 98% of it is going to be in the fallopian tube. All right, so in diagnosing an ectopic pregnancy, we know that it takes normally 48 hours for a woman's HCG levels to double. When an HCG level more than doubles, so let's say it triples in 48 hours, that's a sign of an ectopic. And then can you think of another cause that might be related to a doubling, more than doubling in 48 hours? If you've said multiples, you're completely correct. So multiples will also do this, so twins. Okay, the major complication of an ectopic pregnancy, right, is that it ruptures, and this can put mom into hypovolemic shock because she's going to be bleeding. It's immediate surgery, and she normally loses the tube. If we diagnose it before rupture, there's two different treatment plans. So hopefully this is diagnosed early before a uterine rupture occurs. I'm sorry, a fallopian tube, not a uterine, a fallopian tube rupture. But the treatment for it, if we diagnose it, is that she needs to have surgery to remove that ectopic. If we do that surgery before she ruptures, we usually can save the tube, or she can be given a treatment course of methotrexate. And how methotrexate works as a medication here is it's a folic acid inhibitor. And we know that folic acid is feeding and nourishing that embryo. So if we give her a folic acid inhibitor, we're going to cause the blood to that fetus, that embryo to diminish, and it will cause her to miscarry that ectopic, which is what we want. It's not safe to continue. I will tell you a quick patient case. I had a woman who postpartum, about 8 weeks postpartum, presented to her OB with unilateral pain. She had not gotten a period since having her baby 8 weeks ago, because she was 8 weeks postpartum, but she had an impressive amount of pain. Nobody did an ultrasound or a pregnancy test on her. They said it was probably just pain, postpartum 8 weeks out from her vaginal birth. She presented in the ED 48 hours later with a ruptured ectopic pregnancy. She lost her left tube. I then saw her a year later. She did conceive again. She came in for care early. It was diagnosed to be an intrauterine pregnancy, so in the right place. But it took them a while to get pregnant because she only had one functional fallopian tube, which clearly your chances, when she's ovulating, it's an every other type of situation. It's not as easy to get pregnant when you only have one tube. Okay, the last thing I'm going to talk about causes of bleeding is a molar pregnancy. It has 3 different names: molar pregnancy, hydatiform mole, or gestational trophoblastic disease. This is when the fetus doesn't develop, but a placenta sort of on steroids develops. It's proliferative, it's edematous, it looks like grape-like clusters. This patient will present looking much more pregnant than she should. She'll have excessive nausea and vomiting, she'll have bleeding, and her HCG levels will be higher than they should be. This is what a molar pregnancy looks like from your textbook, and this is what it looks like on a cross-section of a uterus that, you don't need to have a hysterectomy when you have this, but for whatever reason, this is a hysterectomy image of gestational trophoblastic disease. So there's no fetus in here, it's all abnormal placental development. Okay, so if a woman has had a molar pregnancy, that molar pregnancy needs to be removed, usually with a D&C or a D&E. Once it's removed, what's really critical is her follow-up. Within the first year, a woman who's had this can develop trophoblastic malignancy. So it's called a choriocarcinoma. It's a cancer. How do we know that she's developed this cancer? Is that she would start to have a rise in her HCG levels. She's not pregnant, but her HCG levels will go up because she is developing this choriocarcinoma. So what is the intervention? What's the nursing care with somebody who's had molar pregnancy or hydatiform mole? Is the follow-up and the teaching that she cannot get pregnant for 1 year. She needs to be on birth control. She can't get pregnant for 1 full year because every month we need to monitor what her HCG levels are. They should be at 0. If they start to go up, we know she's developing choriocarcinoma. And I have written down here, it's every month for the first 6 months, and then we go a little further out, every 2 to 3 months for those follow-up 6 months. But this is really hard if you want to be pregnant and you're being told you can't be for a year. But the education about why is hugely important. This again is showing you a molar pregnancy. All right, I want you guys to look through placenta previa and placental abruption. We're going to talk about the differences. So placenta previa is when the placenta is the presenting part, right? So here's the cervix and the placenta is the first thing presenting. Think about, can we deliver that way? What will happen if this cervix opens and the placenta is the first thing there? Think about the method of delivery for that. Placenta abruption, I want you to think about the delivery, how you would deliver with this too. This is the uterus. This is now blood and separation. The placenta has separated from the wall of the uterus. Think about what that's going to mean for that fetus. And we'll go through and talk about the clinical signs and symptoms, but I want you to look up and be able to speak to the signs and symptoms of a previa versus an abruption.